Uh, Good afternoon, everyone. Welcome to our session today. For the sake of time, we're going to start with the session, and I hope the rest will join in the meantime. Today's webinar is organized by Medical Research Lounge and Prana Events as part of the pre-conference CME of the 9th Ethio Health Exhibition and Congress, which is to be held in Addis from February 20 to 22nd at Millennium Hall. This particular webinar is going to focus on the scientific aspect of the medical um, community. And the particular topic is on translating research evidence into actionable policies and programs in Ethiopia, a very timely topic, which is going to be provided by Professor Mirkuze Welde. I hope everybody knows Professor Mirkuze, but just to summarize who he is, he has a very long CV, which I can't read out here, but just to introduce to you, for some of you who don't know him, Professor Mirkuze is a health policy and management specialist with 20 years of experience as a researcher, educator, and policy advisor in public health and health policy and systems management. He has led several health policy and systems research projects focusing on community health systems, maternal and child health service quality and utilization, health equity, and quality of health services. He's a very well-published author, having more than 90 peer-reviewed publications. Currently, he's a health policy and systems senior advisor at the Ministry of Health Ethiopia. He's also the Deputy Director for Evidence to Policy Workstream of the FNOT project of Harvard Chan School of Public Health, which is based in Addis. He's also an adjunct health policy and systems professor at the University of Technology, Sydney in Australia, and also 3 universities in Ethiopia, namely Bahar Dar, Walaita Sodo, and Jimma universities. Professor Murkuze, with his ample experience in the field, and I think I must have missed it here. Professor Murkuze is also the editor-in-chief of the Ethiopia Medical Journal. His publications, his professional journey is definitely going to motivate most of you. And I think instead of just reading out everything here, it would be very great if you can reach out to him on LinkedIn and you can visit his publications on his personal ORCID account, which you can access in the chat below. So I will be moderating the session. My name is August. I'm a medical doctor and public health specialist, and I'm the founder and general manager of Medical Research Lounge. We're going to go ahead with today's session, and Professor Murkuze will start by presenting his slides, and then you can keep your questions until then, and we will have ample time for Q&A. You can also drop it in the chat box and I'll collect it and I'll present it to Professor Murkuze for a discussion later. Once again, thank you for coming. Over to you, Professor Murkuze.
Thank you so much, Dr. Tigist, for inviting me this, and I'm really honored to have this opportunity to talk on this particular topic. So I will try to be very brief and make sure that we have enough time to discuss on based on your questions and queries. So this will be my outline. I will briefly talk about what evidence is and then describe the concept of evidence-informed decision-making, or EIDM, then research evidence products that we use in EIDM, challenges in EIDM, and then I will try to give you a case example trying to depict how evidence-informed decision-making is happening in the Ethiopian health system. So to begin with a description of what evidence is, this is just a factual knowledge gained through observation or experimentation in support of a conclusion. So this is like a very broad definition of what evidence is. To better understand the meaning of evidence, we can talk about types and contextual relevance of evidence. In terms of type, we can talk about tacit or colloquial knowledge, which is tacit evidence or colloquial evidence, meaning these are knowledge gained through experience, knowledge leading to norms and opinions of professionals, communities, managers, and so on. So this is one form of evidence. The other form of evidence is scientific or research evidence, which means this is knowledge gained through systematic inquiry, and because of the transparency of the approach to generating this knowledge, this is reproducible in nature. And usually when people talk about evidence, they refer to research or scientific evidence. But we have to remember also that there is tacit or colloquial evidence, which is a result of informal experience, communication, interaction among actors in the system. The other relevant description of what evidence is a contextual relevance of an evidence. An evidence could be a global evidence, which is generated through systematic review, whereby we try to pull the evidence existing on a particular topic from around the world. And that's usually useful to different contexts in different parts of the globe. While local evidence refers to mainly primary evidence, of course, we can also do synthesis of primary evidence for a particular locality, like for Ethiopia or a particular region in Ethiopia or elsewhere. So the traditional hierarchy of evidence is very well known to many in this webinar, I'm sure. Looks like this one. And why I brought this into your attention is to make this the next point. The point I wanted to make is this hierarchy of evidence only considers one type of question in research inquiries, and that is, does it work? If the question is effectiveness, then this hierarchy of evidence, which we are familiar with, is relevant. And as you know, randomized controlled trials and systematic review of randomized controlled trials are at the top for very clear reason. But for determining the usefulness and the quality of evidence, the question matters. If it's effectiveness, as I said, this one would work, but we would need to qualitative evidence and other forms of evidence to answer questions such as, how does it work? Is it safe? And so on. So contextual description, when contextual description matters, when mechanism and processes are important in trying to answer the policy relevant question, then qualitative evidence might be a lot better than an RCT on that particular topic. So we should not be really too focused on this traditional hierarchy of evidence. Coming to translation, is a dynamic and iterative process that includes the synthesis, dissemination, exchange, and ethically sound application of knowledge. And the aim in this process is to try to improve population health service delivery, and product development, and strengthening of system used to deliver services and to produce health products. And as you can see from this diagram, the process of translating evidence is a very complex and iterative process engaging different sectors, including the community, the health sector, government structures, the education sector, research initiatives, and so on. So if you are trying to engage in translating evidence, you have to realize that there is like a back and forth re-engagement and engagement among the actors. So it begins with problem identification, goes into creating the knowledge creation, then you synthesize the knowledge in a format that would be relevant to the context within which you are implementing a program or a policy. Then you implement it, evaluate it, then the cycle goes on. But this is not cyclic. As you can see from the arrows, there is a lot of back and forth and iteration in the process of making use of evidence to inform decision making. So what is EIDM, or evidence-informed decision making? This is the latest definition provided on the World Health Organization EIDM guideline. They defined it as a process whereby you identify, appraise, then mobilize the best available evidence for safe and effective health policies and programs. And from the definition, you can see that you strive to make sure that you are including all relevant evidences and synthesize them in a format suitable to your context. As you can see from these Venn diagrams, the role of evidence in this EIDM process is just like a component or a part of the decision-making process, because the expertise is important. The community health issues, local context, cultural, religious, historical issues are very relevant in making decisions, not just the evidence. Public health resources are available to carry out interventions is also very important, and community and political preferences and actions are essential. So a decision maker in place would take into account all of this before making decision, not just the best available evidence. So when we say EIDM, we are referring to use of or consideration of all of this, not just the evidence. Research evidence products that we use in EIDM might be of different forms. At the base of this diagram, you see evidence inquiry, where you generate, we call them usually primary research. This is the form of evidence which results by collecting data firsthand. So it could come from a collection of data by the researcher himself or herself, or could be using routine data that's generated by the health system, or could be a result of monitoring and evaluation processes that support the program implementation or surveillance. So this is primary research. Then next in the ladder, you have evidence synthesis, which refers to secondary research. This refers to systematic reviews and meta-analysis, rapid reviews, burden of disease studies, it could be quantitative or qualitative reviews for that matter, modeling and so on. But the last one, which is ready to use product for policymakers, are tertiary research or evidence products. These are produced in the form of policy briefs, evidence briefs, policy brief, issue brief, or technical brief. Then they inform the development of guidelines, patient decision aids, and HTA or health technology assessment procedures. So EIDM has, being a very complex process itself, the EIDM is challenged by several roadblocks in its actions. So the first one we might mention is a disconnect between those who produce research evidence and those who are supposed to use the evidence generated by the producers. If you are coming from academia, you would know that there is very little linkage or interaction between the health system players, including providers, health managers, policymakers at the top, and so on, and the researchers within the universities and research institutions that we have got. And this is not the reality only in this country. This challenge exists in many settings. And lack of institutional capacity and resources to translate knowledge into policy and practice, lack of relevance, even if evidence exists, that might not be relevant for the health problem or practice issue, or poor access to existing, even if it is relevant, it might not be accessible, and lack of coordination among the different actors is also one of the challenges. This is what I meant by the complex interaction between the players in the EIDM ecosystem. So the interaction in processes look like this one. So it begins with evidence, and evidence should be generated for effective evidence-informed decision-making process. It should be generated with the engagement of the different stakeholders. That's why you see a bidirectional arrow on the left side. Then you have again the players, the stakeholders, the healthcare delivery system players, and individuals in the middle. And practice is on the right side. Again, practice will be evidence-informed if and only if there is enough interaction between and among the different actors. This, if properly happens, then would affect population health development in the system. To give more emphasis to the role of translators, I have brought this Venn diagram to your attention. So, there are three groups of actors. We can group the different actors in the previous slide into three. So translators, policymakers, and evidence producers. And as you can see, all these three actors have their own area of work and their own interest and focus. But for evidence-informed decision-making to happen, there should be like a common space, as you can see in the intersection areas of the Venn diagram, a common space where there is connection and interaction between evidence producers, translators, and policymakers. So in the common space, you see technical staff in government, advisors, embedded experts. These are a sort of knowledge brokers trying to connect these three worlds of different interest and different culture and different language. So this is like a sort of facilitator playing in the middle. And so if I would say that's enough as a way of introduction for our topic. Let me give you like a flavor of what happens in our health system to date in terms of institutionalizing evidence-informed decision-making. So these are the challenges. In one study, which was conducted in 2016, depicts these different problems or challenges impacting evidence-informed decision-making in the Ethiopian health system. These problems depicted on the fishbone diagram are grouped into four. One is about existing evidence being unavailable. The second one is needed evidence not always existing. The third, available evidence not always used even when it's available. And the fourth one, existing evidence policy not consistently analyzed, to make it better informed by existing evidence. So if you look deep into the fishbone diagram, you will see that there is disconnect between the actors. There is a problem of priority setting. There is a lack of coordination among actors, and so on. So those common challenges I mentioned earlier in our global overview also happen in the Ethiopian health system. So these are the actors in the ecosystem, the different actors and their level of interaction in the different functions of EIDM. So strategy and priority setting, there are no actors, but recently the Ministry of Health has established the Policy Strategy and Research Office, which is supposed to coordinate priority setting and strategizing the conduct of health research in the country. Then generation and synthesis, there are actors like academic institutions, research institutions, and knowledge translation platforms like the Tuberculosis Research Advisory Committee, RMNSH Research Advisory Council, Scientific Advisory Panel in Oromia, and so on. So these are ad hoc committees or councils trying to bridge between researchers and research users in the health system. In terms of translation, the role of this translation, knowledge translation platforms is much higher, while coordination has not been attended yet. But as I said, the new structure is mandated to do this. So these are some of the areas where there are gaps in terms of handling EIDM in the Ethiopian health system. The policy structures, the policies and structures for EIDM in the country, if you look at the revised national health policy, you will see a clear statement indicating that there will be emphasis to making sure that policies and programs are evidence informed, in trying to make use of existing data, routine data, and survey and other source of evidence to inform decision making at all levels of the health system. So there is an enabling environment in terms of policy. The health sector development and investment plan also states this very clearly. As I mentioned earlier, a year and a half ago, a policy, strategy, and research lead executive office at MOH has been established, which is an enabling and coordinating structure in terms of institutionalizing evidence-informed decision-making and research institutions of MOH and their KT units. I mean by EPHI, Ethiopian Public Health Institute, and its KT department, AHRI, or Arman Hansor Research Institute, and its knowledge translation department are enabling environments trying to support this process. And the knowledge translation platforms I mentioned earlier, although they are ad hoc and voluntary-based structures, they are really facilitating the interaction between policymakers and researchers in the country. And research universities and research institutes are also making a lot of contribution, particularly in terms of generating evidence. So there are enabling environments, policies and structures, and the environment is really ready for nurturing and growing and institutionalizing evidence-informed decision-making. Also, we are not yet there. So to give you an example from the Maternal, Child and Adolescent Health Service Lead Executive Office, one of the research, the knowledge translation platforms I mentioned earlier is the Research Advisory Council at that department. Historically, the Research Advisory Council had seven thematic groups with the different boxes you see, but it evolved into more thematic groups over time based on demand. But recently, its current structure has changed to make sure that it corresponds to the different desks within the department. So these are the four desks that manage maternal and child health programs within the country. And the Research Advisory Council has these different thematic, sub-thematic groups. And you might ask, who are the members of the council? The council is composed of researchers from universities and program managers from MOH, from the different desks, and partner organizations. So this group regularly interacts with the desk managers to identify policy relevant questions, do synthesis of evidence, and provide evidence briefs to inform guideline development, policy revision, and so on. So these are some of the key objectives of this platform at the Maternal and Child Health Department in the Ministry of Health. So they support the department in terms of identifying research, policy relevant research area gaps, then promote evidence use. They interact with technical working groups and task forces to make sure that the research evidence that's provided is used to inform decision making, and they also provide technical input for policy crafting and policy development. In terms of operation, there is a secretariat at the lead executive office, coordinated by the Research Advisory Council coordinator. Each sub-team has a chair and co-chair. Regular annual planning meetings happen to make sure that the Research Advisory Council always has something to take care of every year and in schedule. And individual sub-teams meet virtually and in person at different intervals. And the chairs and co-chairs regularly communicate with the RAC coordinator and, of course, the lead executive officer at the department. So these are some of the outputs of the Research Advisory Council. It has supported the introduction of, for example, UBT, NASG, and HEXA, delivery of quality oxytocin in terms of child health, hepatitis virus introduction, yellow fever vaccine introduction, pneumonia incidence estimation, and so on. The other sub-theme was early childhood development. They have supported situational assessment, 10 years strategic plan development. They have also supported M&D framework development for this new program within the health system. And the PMCT also had a national survey designed and conducted by the Research Advisory Council itself. In terms of expansion, with out of the inspiration from the Research Advisory Council, now the Policy Strategy and Research Office has been established at the Ministry of Health. The PMCT Research Advisory Council continues to operate. The Nutrition RAC, a new Research Advisory Council, IQ RAC, or the Innovation and Quality RAC has been developed. Health Policy Advisory Council has been also set up, learning from the experience of the RAC at MSH department. And this has also, the development has also gone to subnational levels in Oromia, in Amhara, and the department also has other knowledge translation platforms. There is capacity building opportunity for staff and stakeholders, research conference for connecting researchers and policymakers for discussion on up-to-date evidence, and a regular brown bag-like session, which we call a Galgal session, to do research evidence presentation at the department within the Office of the Health Managers to make sure that they are provided with up-to-date evidence to improve their appetite in terms of seeking evidence to inform decision making. So this is all from me. All questions and comments are welcome, and I think we have enough time for discussion.
Thank you very much, Professor Merkuze. It was a very brief and very nice presentation. I believe everyone has learned a lot, especially this is a very unique topic for most of us because as a country, uh, well, in research, we're a bit lagged compared to where the Western culture is, the research culture is, and talking about evidence can be a bit complicated because most of us are struggling with conducting a basic research at the clinical or public health level. So I think before I ask further elaboration on some things, I would like to forward some of the audience questions for ease of uh, communication. I think it's better if I display it. Can you see it, Prof? Can you see my screen? Professor Merkuze, can you see the screen that I just shared?
I just stopped sharing, so you can share now.
Yeah. Okay, let me share it again. So
Yeah.
I will add the questions here on the screen so that everyone can see it.
Okay.
And the audience is welcome to ask by on the chat box, or I can give you permission to speak. You can raise your hand and you can ask as well. So we can start with the first question, but before that, I see that some of your colleagues are also in the meeting, which is really nice. Thank you for coming. I see Professor Zenuel, Dr. Salamon, and other people. If there's anything that you'd like them to add or emphasize on, I'll leave the decision for you. You can invite them to add or elaborate on some things. In the meantime, you can start with the question. So the first question is, it says, how could we connect the research output and its users, such as policymakers, conscious program, and guideline developers in Ethiopia? The two are apart because of interest of the research output, data fabrications due to lack of resource, busy clinicians, and unlike to search outputs. I think
Yeah.
you have grasped the idea. This is a very good
Yes.
question and something that I would also like to ask. So you can start by reflecting on this one.
Yeah, thank you. Thank you so much. This is an excellent question. As you said, yeah, but I think the person who forwarded the question has picked the most important thing in terms of, the barrier for evidence-informed decision making, which is lack of trust between and among the actors within this ecosystem. Yeah, so what is the solution is the question, I guess. So the solution is working together from the very beginning. That means trying to co-create the evidence from the very onset. So who would like somebody to tell him or her while they don't know how the instruction has been reached or made up. So the most important solution, I would say, from experience, we have to engage as researchers. We have to engage, be it a clinician, other providers, or policymakers, and so on, at the initial stage, particularly in determining the question. So what question do they want us to research, to examine? You might think they are too busy to do that. If you are really trying to engage them at the early stage, they will be more interested. Why? Because these people have, because of the different engagements they have through the program, they have got, first-hand experience about the problems, coming now and then in the system. So because of their knowledge, they will guide you which question to ask and where to search and so on. You are, as a researcher, equipped with the skills, the methodology, and so on, the techniques of inquiry and so on. but the real knowledge about the program exists with the program managers, with the clinician, or the other practitioners. So if we begin with their question, they will be interested to make use of it. So I would say the most important solution is to really make sure that we ask the right question. And the process of crafting the question should happen with those who are supposed to use your evidence, if you are really interested in translating it or making sure that it is used to inform practice and policy. So, and you make sure that you engage them not only at the beginning, but also at the different stages, during the analysis, during, even crafting recommendations. Recommendations should be also crafted with those who are supposed to use it, because more practical, more feasible recommendations would emanate from a discussion that involves the users and those who have knowledge of the context in which the study was conducted. I hope I've addressed the issue. And Samuel, maybe as Tegist said, if you have anything to add, you can jump in anytime. And Dr. Salamont.
Yeah, thanks. This is hi everyone. Thanks, Marcusi, for the fabulous presentation, and thanks for coordinating this. I just wanted to sort of give a crude framework of what's important in bringing researchers and research output users together. I think we need three big components. One is the culture. That means including trust, developing the trust and relationship. The other, we need the capacity, the competence. Both the user and the producer need to have specific skills. For example, collaborative skill, cultural competences, and using the proper terminologies, using the proper format in developing the research and communicating the output. So these are competences, just examples. The third part is the structure. I think we need to have a sort of platform for tools to communicate. I think what Marcusi has been describing is a sort of innovative way of creating a space or structure to bring the researchers and the research users together. For example, the Research Advisory Council, it's one innovative way of bringing, that's a structure. Even though it's a platform, it's a structure. So I think we need to have these three together, to have an effective production and use of research outputs, and to have a proper bridge between the two. So this is important to consider, but at the same time, we need to be very much creative. There is no one way, there are diverse ways of doing things. So be brave, creative, try to use opportunities, as well as create new approaches. Test them. If they work, continue or expand. If not, modify them. I think this is relatively a new idea, so I think there is a big opportunity for people to be creative and innovative in terms of improving this function. Over to you, Tegist.
Thanks.
Thank you very much, Professor Samuel, for adding. I think Dr. Solomon also want to add something, so let's leave the floor for him.
Thank you so much, Tegist. Thank you, Professor Marcusi, for a very insightful talk. I think, and of course, Tegist for setting up this kind of forum. I think there is no better time than this, that we gather together and talk about, using evidence to be able to inform policies. Then I believe there is a huge inefficiency in terms of utilization of research output in this country. By the way, I would like to take this opportunity to thank the whole FNO team. I think Professor Samuel, Professor Marcusi, in terms of setting up a sort of culture in this country whereby you're serving as I would say as an engine in this country, bringing up different stakeholders around research and being able to this country use research to inform policy and improve clinical practice. So, and having said that, the huge problem when it comes to utilization of research in this country is the culture. I don't believe that we're yet there, believing in that really, really research matters. I think it all starts from there. So if there's anything big that we do in this country, it has to be cultural revolution. Making all like it not only of academics for sure will believe in research. That's what they do. They produce research. But when you come to the policymakers and programmers, I'm not sure how many of those people truly believe in evidences. So in this country where people trust more of their gut feelings than evidences, setting up those kind of culture won't be easy. I know you're trying your best to bring this, and I think we've come so far, and I believe that we need to still go quite a lot in terms of having creating this sort of culture in the future as well. So I think keep the good work. I believe this kind of platforms could also serve in terms of contributing in this cultural revolutions. We've already started, showing people how evidence are very powerful and improving whatever we want to improve. So it is coming slowly, and hope would see a lot of change in the near future. Uh, uh, Building up in what I've already mentioned earlier in terms of inefficiencies in research in this country, we know there is lots of research output from academia, a tremendous output from academia. We spend a lot of resources in research, especially individuals in academia. But if you look at the utilization of those outputs, and I would say it's less than 1%. I think you know that much better than I am. So I just want, I think maybe Mercury to reflect on this. Where are we in terms of utilizing resources? Researchers in terms of informing policy. Are we tracking that? How would the trend like? I know when you start, it must be very, very low, but where are we now? Or first of all, are you sort of tracking that as well? How much of the research output in this country are put into use in terms of informing policy? That is my first question. And the second question is, and I know there are master's PhD students in this platform and attending the session. If you look at a student research, it could be a master's or a PhD thesis, and every student put as a justification, as a significance of their study, as this particular research is done so that it would inform policies. But I just want to create this opportunity for students to have that clarity. What sort of research truly inform policy? By the way, is a single study, is it possible for a single research to inform policy? How big has to be the research to inform policy? If not one research, how many researches? I think this could be a good opportunity for the FNO team to quickly jump on this and reflect so that students could also have clarity, and they're not going to say that whatever research they do is going to inform the policy. Over. Thank you so much.
Thank you so much, Dr. Solomon. Maybe, a lot of questions are coming in, but let me begin with what was just pointed out by Dr. Solomon. In terms of research utilization, I would say we are not there yet, as you said, but we are progressing. From my experience at the Ministry of Health, at different regional health bureaus, I have seen that the culture is changing slowly. So, and that's because of intentional, innovative approach to promote use of evidence to inform decision making. At the MSA Directorate, where I have mentioned earlier, now if you go to that department and tell them, for example, to revise a guideline or change a certain intervention, they will ask you, what is the evidence? If you don't have the evidence, then they go to the Research Advisory Council for it to do a synthesis of the existing evidence. So now we are having policy managers, who ask questions such as, is it cost effective? Would it work in the Ethiopian context? And so on. So this is really a very good sign, I would say. In terms of tracking it and documenting that, I think we have got a lot of gap, but our team now is trying to develop a systematic way of tracking such efforts in the future. And rightly said, we need to do that. For the students, research, masters, PhD students, as you said, yes, we usually read to inform policy and practice and so on. But what research, what kind of research would inform policy? As I have tried to explain earlier, research that's based on the demand of the policymakers, the users, would be most likely used to inform decision. Why is that? Because it resonates to their need, to their area of concern. For example, if you go to a certain, if you do your PhD thesis and come up with like a big report, and a bunch of publications, and come to a policymaker and tell them, to translate this one or use it to inform your decision, that's not going to work. Why? Because in the first place, it was not their question. So the questions that they have not asked, they don't usually use it. So what's the best way for MSc and PhD students to make sure that their research output is used? It is to begin with the question of policymakers. How do they do that? They have to go to zonal health departments, woreda health offices, regional health bureaus, the Ministry of Health, and ask about the program. Do quick assessment rather than do the assessment, the quick assessment to come up with a question on the desktop. And how big should research be? I would say this really depends on the availability of evidence in that area of inquiry. If in that area of inquiry, if there is very little evidence, then even a single study would be of interest to the policymakers. But the strength, the quality, and the scope of the study has to be assessed. That's one of the skills Professor Sunil was mentioning for a manager to have before making use of research. Not all published studies are of good quality. So there is a need for policymakers and those, translators for them to have the skill to appraise, the quality and the scope and the relevance of the evidence before they make use of it. So how big should it be? If we have a lot of study, we prefer systematic reviews, a pool of evidence. But when there is no evidence in a certain area, we might use, a certain evaluation report or quick assessment as an evidence, for the demand. So the next question in the list is, how can we proceed with AI? AI, as you might understand, is a tool. So this tool has to be carefully used, I would say. And digital health, low literacy, yes, these are challenges, but it has to be made use. And we cannot shy away from using technology. We have to manage the risks and make use of AI in the health system as appropriate. And another interesting comment is number 3. A colleague from AHRI states that they have got 1,074 publications with very little output to inform healthcare practice and health policy making in the country. I think this is a typical example of the disconnect between those who generate evidence and those who are supposed to use it. From our experience, we have seen that there is this disconnect, not just between institutions, even within institutions. You know, when people are provided the task of generating evidence, they automatically abandon the idea of, caring for or informing, shaping programs. When people are assigned for programs, then they forget research evidence altogether. So there should be, that's why we suggested an innovative way of creating a space, a permeable space that connects these two different worlds. And I think, which one is the next question?
Number 5.
Number 5 is the next question. So what is that?
Given that early engagement with policymakers is crucial for translating research into action, what practical strategies can researchers use to ensure that policymakers remain actively involved throughout the research process rather than just at the beginning? Even when policymakers are engaged early in research, challenges like shifting political priorities and limited resources can hinder implementation. How can researchers and policymakers co-design adaptive strategies to ensure evidence-based policies remain relevant and actionable over time?
Yeah, so this is a very good comment. Let's remember that policymakers have the responsibility of making decisions. Managers, practitioners, clinicians, they do, they make decisions on the spot or, through a cascade of processes. In doing so, it's not only the evidence that counts. As you said, the political, economic, cultural, and other values in the system do really matter. The preference of patients and populations, this all matters. So they have to strike the balance in terms of navigating this complex process of ensuring evidence-informed decision making. So there is a need for them not just to focus on the evidence, but also to make sure that they comply to the political environment, the resource constraints, and the other variables that I mentioned. So these innovative initiatives that we propose should really take note of all these complexities and not demanding too much from the policymakers, and understanding the context within which they are operating is very, very important. And how do you see the power of some strong institutions? In policymaking, the role of power should be given due attention. Power might emanate from the resources that you have, as you said, financially, could be as a result of your access to knowledge, could be as a result of other sources. Whichever it is, in the policy making process, who wins depends on the balance of power. So the balance of power sometimes might result in ignoring the best available evidence in making decisions. This is undeniable and is a reality throughout the world, not just in this country. So as policymakers and as evidence providers, as contributors to the process, we have to accept it. We cannot shy away from the political flavor of the policymaking process. There should be a way to navigate through and try to make sure that evidence really counts and contributes in terms of setting agenda, in terms of making contributions in the decision making. But remember, the most powerful always wins in the policy making process, and you might find it unfair. And another question, probably, if we have to prioritize the text for because of time.
Yeah, I think you can skip some of the repetitive questions. I can also share this the list of questions. Some of them are like redundant, I guess. If you feel like there is something unaddressed, you can just read the Ed's question for yourself and add something.
Yeah, so one more question, I would say on number 8, we have how much is the quality. You know, quality is an issue in the while informing the decision making. Quality is very important. We cannot compromise on quality because the decisions we make, we know that they impact people's health. So because of that, there is no way we push for use of evidence, without looking at its quality. As I said, the level of or the availability of evidence in that particular area of inquiry really matters. Where there is no enough evidence, you still use what's available, but be cautious in terms of making sure that is it of quality, is it contextually relevant, is it sensitive to the political, economic, and other contextual factors, and so on. This has to be checked, not just the research methodology and so on. In terms of language, yes, could be a barrier, but we do as we do in conducting systematic reviews. We try our best to make sure that we include the best available evidence while trying to summarize the evidence in a particular area of inquiry. But for example, if we are synthesizing evidence to inform decision making at the district level, we make sure that it's relevant to that level, and we don't miss, at least to the context we are concerned with. Is there any platform in Ethiopia to present research output, such as policy brief? Very interesting question again. The different health system organs in the country try to organize research conferences, as you might have seen. EPHI does that. Even MSH lead executive office tried a couple of those three rounds of research conference. Amhara Public Health Institute does that. Oromia Regional Health Bureau. Our observation in this area is that these are really academic research conferences. They are just duplicating what is done by universities. So what do we recommend to make sure that these platforms are relevant for policymaking? Focus on program relevant research evidence, systematic reviews, program evaluations. Could be quick review of programs, national surveys trying to track progress, and so on, and be presented in the form of policy briefs, not ordinary abstracts. So the format of research conferences or evidence summits organized by health systems should really be geared towards focusing on policy briefs, technical briefs, rather than the conventional methodological conferences. Thank you very much. Any more questions? Maybe if you...
I think, thank you, Prof. If there are more questions, they're welcomed. I can forward it to your team. By the way, this shouldn't be just a one-time discussion, considering the novelty of the topic for us and its early stage in the country. We can use a lot of discussions to learn about it and to find our place in contributing to this cause. So I think we will create other platforms where we can discuss further. So for the time being, I'll forward the questions. And if there are things that you'd like to share, I can share through the network. So I think in addition to that, this is just a pre-conference CME session. the 9th Ethio Health Exhibition and Congress has organized the very first scientific session this year. So in that scientific session, I hope to see everyone there because we'll be able to discuss such things and also connect and network with the different professionals in the country, and also from over like 10 countries would be involved in the exhibition, and we can discuss it there. So, so what I'm trying to say is that this is not the only opportunity for us to discuss about evidence-informed decision making. The conversation will continue, and I'll also send the questions for Professor Murkuze and his team so that they can address it, and we'll be able to get back to you and share their responses, relevant points through email. So I think for now we have addressed a lot of things. I think Professor Murkuze, if you have any last remark you'd like to share with the audience, I'll give you that opportunity and we can wrap it up.
Thank you so much, Dr. Tegus. Yes, I'm really grateful to had this opportunity of talking to the audience on this very, very relevant topic. As you said, it's new to many people, but is very important at this point in time because of the pressing issue of resources, the pressing issue of increasing demand in terms of population health development and so on. I am very much ready to really have a continued engagement with your team on this topic. And we have got evidence to policy workshop or training of 3 days, which really examines this topic in depth and provides practical guidance to people. And I would say we will have opportunity to provide that training to whoever is interested in the future. Thank you.
Thank you very much, Professor Murkuze, for making the time considering your very tight schedule. We have learned a lot. I was like writing at some point I was like a bit delayed in responding. It's because I was writing and learning from what you were sharing with us. Thank you very much. It was a very educational session. Like I said, I hope we'll continue the conversation in the future. And thank you everyone for coming. There is a certificate of participation which you can earn by filling the form that I just shared. So thank you, everyone. Have a great time.